occurs in two forms, marasmus and kwashiorkor, which differ in their clinical features. Is a form of protein energy malnutrition occurring chiefly among very young children in developing countries, particularly under famine conditions in which mother's milk supply is greatly reduced. Marasmus result from the inadequate intake of both protein and calories. Persons with a similar type of protein energy malnutrition, kwashiorkor, do not obtain enough protein, but still consume a moderate number of calories. Marasmus is characterized by growth retardation and progressive wasting of subcutaneous fat and muscles. Other symptoms may include diarrhea, dehydration, behavioral changes, dry, brittle hair, loose skin. Marasmus can be treated with a high-calorie, protein-rich diet. Severe, prolonged marasmus may result in permanent mental retardation and impaired growth. And kwashiorkor, also called protein malnutrition, condition caused by severe protein deficiency. Kwashiorkor is most often encountered in developing countries in which the diet is high in starch and low in proteins. It is common in young children weaned to a diet consisting chiefly of cereals, grains, sweet potatoes, or similar starchy foods. The condition in children was first described in 1932. The term kwashiorkor means deposed child, deposed from the mother's breast by a newborn sibling in one African dialect and red boy in another dialect. The later terms come from the reddish-orange discoloration of the hair that is characteristic of the disease. Other symptoms include dry skin and skin rash, pot belly and edema, weakness, nervous irritability, anemia, digestive disturbances such as diarrhea, and fatty infiltration of the liver. In addition to the protein deficient diet, other causes of kwashiorkor include poor intestinal absorption, chronic alcoholism, kidney diseases and infection, burns or other trauma resulting in the abnormal loss of body protein. Protein malnutrition is associated with deficiencies of one or more other nutrients and of calories. When the caloric intake is inadequate and the level of dietary proteins is barely adequate, protein malnutrition may still develop, for some of the protein is metabolized to supply the body's energy need. Marasmus is a severe form of malnutrition, specifically protein energy undernutrition. It results from an overall lack of calories. Marasmus is a deficiency of all macronutrients, carbohydrates, fats, and proteins. If you have marasmus, you lack the fuel necessary to maintain normal body functions. People with marasmus are visibly depleted, severely underweight, and emaciated. Children may be stunted in size and development. Prolonged marasmus leads to the starvation. Marasmus and kwashiorkor are two different variations of severe protein energy undernutrition. Marasmus is a deficiency of all macronutrients, while kwashiorkor is a deficiency in protein predominantly. Kwashiorkor occurs in people who may have access to carbohydrate, bread, grains, or starches, but lack protein in their diet. Marasmus has a wasted and shriveled appearance, while kwashiorkor is known for causing edema, swelling with fluid, especially in the belly and the face. Marasmus can affect anyone who lack overall nutrition, but it particularly affects children, especially infants, who require more calories to support their growing bodies. It is more common in developing countries with widespread poverty and food scarcity, and where parasites and infectious diseases may contribute to calorie depletion. In the developed world, elderly people in nursing homes and hospitals or who live alone with few resources are more at risk. When the body is deprived of energy from food, it begins to feed on its own tissues. First, adipose tissues, which is the body fat, and then muscles. It also begins shutting down some of its function to conserve energy. Cardiac activity slows down, causing low heart rate, low blood pressure, and low body temperature. This leads to heart failure in some cases. The immune system is also compromised, making undernourished people more prone to infection and illness, and slower to recover. Children with chronic marasmus will not have the physical resources to grow and develop as they should. They may be stunted in size or have developmental delays or intellectual disabilities. These effects can be lasting even in the children who receive treatment. Parts of the digestive system also begin to atrophy from the lack of use. This means that even when people do have food to eat, they might not be able to absorb nutrition from their food effectively. Marasmus can lead to food aversion. What are the main causes of marasmus? The main causes of affecting all ages include poverty and food scarcity, wasting diseases such as AIDS, infections that cause the chronic diarrhea, anorexia. Additional causes affecting the children include inadequate breastfeeding or early weaning of infants, child abuse and neglection of child. Additional causes affecting the adults include dementia and elder abuse and neglection. What may be the external signs of marasmus, which may be visible wasting of fat and muscle, prominent skeleton, head appears large for the body, face may appear old and wizened, dry loose skin, dry brittle hair or hair loss, sunken fontanelles in infants, lethargy, apathy and weakness, weight loss of more than 40%, BMI should be below 16. What other symptoms and complication can marasmus cause, which may be dehydration, electrolyte imbalance, low blood pressure, slow heart rate, low body temperature, and gastrointestinal malabsorption, stunted growth, developmental delays, anemia, osteomalacia or rickets. How is marasmus diagnosed? Healthcare providers will begin by physically examining the person's body. Marasmus has some telltale physical features. the primary one being the visible wasting of fat and muscles. People with marasmus appear emaciated. The loss of fat and muscles under the skin may cause the skin to hang loose in folds. Beyond appearances, healthcare providers will measure the height or length of the person's body and the circumferences of their upper arm. Healthcare provider uses a few different charts to measure a child's or adult weight to height ratio against medical standards, depending on their age. Marasmus is defined differently on different charts, but it is always significantly below average. They use a chart more people are familiar with. Marasmus would score below 16 on the BMI. The purpose of the scoring is mostly to confirm the diagnosis and rate how severe it is. Diagnosis primarily relies on the body measurements, which are then scored according to the different scoring systems for children and adults. Upper arm circumferences and height to weight ratios help the healthcare providers rate the severity of undernutrition. Height to age ratio help define growth delays in children. Healthcare providers will usually recognize the type of undernutrition based on the physical signs. The next step will be to take a blood test to identify the secondary effects of marasmus, including specific vitamin, mineral, enzymes, and electrolyte deficiencies. This will help determine the child's or adult's nutritional needs for refeeding. A total complete blood count can also help reveal any infections or disease that may have contributed to or resulted from marasmus. They may lack or check a stool sample for parasites. Infection will need to be treated separately. People in treatment for marasmus are at risk of refeeding syndrome, a life-threatening complication that can result when the undernourished body tries to reboot too fast. For this reason, rehabilitation happens in stages. People with marasmus should be treated in a hospital setting under close medical supervision. Healthcare providers who can train to anticipate and recognize refeeding syndrome can help prevent or correct it by supplementing missing electrolytes and micronutrients. The first stage of treatment is focused on treating dehydration, electrolyte imbalances, and micronutrient deficiencies to prepare the body for refeeding. In many cases, these can all be treated with one formula, rehydration solution for malnutrition, given orally or through a nasogastric tube. It also important to keep the persons warm to prevent hypothermia and to treat infections which compromise their meager energy resources. Depending on the individual, it may take several hours to days before they are considered stable enough to begin refeeding. Refeeding begins slowly with liquid formulas that carefully balance the carbohydrates, proteins, and fats. For inpatients, healthcare providers prefer the tube feeding because it allows for gradual but continuous nutrition. Calories are introduced at about 70% of normal recommended values for the person's age. They may increase to 140% of recommended values to meet the growth requirement of stunted children. This phase may last 2 to 6 weeks. During this time period, patients gradually progress to more ordinary oral feeding with solid foods. Since marasmus can recur, a complete treatment protocol includes education and outgoing support for the patient or their caregiver. before they are discharged. In the developing world, this may mean breastfeeding support, safe drinking water, and food preparation guidelines, immunizations, and education to prevent widespread diseases. In the developed world, caregivers may need guidance on how to recognize signs of malnutrition in those they care for. The Malnutrition Universal Screening Tool can help identify the people at risk. In your own community, you can help prevent the Marasmus by advocating for the needs of children and elders who may be unable to advocate for themselves, especially those living in hospitals and care homes. In the global community, preventing the Marasmus means fighting poverty, eliminating food deserts, improving nutritional education, controlling widespread infection diseases, improving sanitation in developing countries, improving elder care in developed countries.